that I ain't going nowhere. I ain't blowing no smoke. I mean, I've been sober, but you should've known it. And I wasn't going.
Alright guys, welcome back to my channel. Welcome back to another video. It's your RN Steph. So today on my channel we will be discussing about asthma. So on previous videos we discussed about sepsis and stroke. So this one will be about asthma. See, I got some books. Right, I got a book. It's the Advanced Life Support book, and it has everything. So first, what is asthma? So asthma is a chronic respiratory condition where the airways in the lungs become narrowed, making it difficult to breathe. So in asthma we have three things: inflammation, narrowing, and mucus. So with inflammation, the airways become inflamed, causing them to swell. With narrowing, the muscles around the airway tighten, further narrowing them. And then mucus, excess mucus, also block the airways. So I drew a little picture. So this is a normal lung. This would represent a normal lung. And this would represent the lung of an asthmatic. So as you can see, the lumen here of the airway, there's different muscles. We know about different muscles that we have, and this is the innermost one. So in a normal lung it is more wide, and in an asthmatic one it is very narrowed due to inflammation, mucus, and narrowing. And these factors make it harder for air to flow in and out of the lungs, leading to some of the asthmatic symptoms that we have. So the narrowing, inflammation, and mucus, all of this leads to symptoms of asthma, such as wheezing. Wheezing is a whistling sound, and sometimes you can hear an audible wheeze. You don't even have to auscultate. Shortness of breath. Sometimes they have difficulty breathing, tripoding with use of accessory muscles. Persons will have a cough, mostly at night. They may have chest tightness, and this is a feeling of pressure or discomfort in the chest. So what are some of the triggers for asthma? You can have allergens such as pollen, dust mites, pet drainer. You can have irritants like smoke, pollution, infections such as colds and the flu. Some stress may cause it, and some medications, and exercise as well in some individuals. So when persons come in with asthma, we would try to get a peak flow reading from them. And this is a simple device that measures how hard you can breathe out. And the more force with which you can breathe out, you get a higher number, and that will be a better peak flow. But if you cannot blow far enough and the peak flow is low, then that's not a good indication that your lungs is working effectively. Alright? So normally we try to do the peak flow before we give any medication. Okay? So treatment wise, we give bronchodilators, that are some inhalers. So relax and open the airways. We have the regular salbutamol and ipratropium bromide. So these relax and open the airway. We give oral corticosteroids, which opens the airways. We give anti-inflammatory, and these reduce swelling and mucus in the airway. So some persons have severe asthma attack, and if the asthma attack is so severe, it can lead to cardiac arrest. So for persons with acute severe asthma attack, they would require aggressive medical management to prevent any deterioration such as cardiac arrest, like I was saying. So we would provide oxygen, and we would like to maintain their saturation at least 94 to 98%. So we do not delay oxygen administration whilst waiting for a pulse oximeter. And in the same time, we give some salbutamol 5 milligram, or we give this oxygen driven. All right. So the main therapy for acute asthma is salbutamol, and repeat doses every 15 to 30 minutes or continuous. All right. We add ipratropium bromide as well, 500 micrograms, 4 to 6 hourly, to beta 2 agonist treatment for patients with acute, severe, or life-threatening asthma. We give steroids as well, and the most frequent one we give is prednisones, 40 to 50 milligrams orally, or we give hydrocortisone 100 milligrams, 6 hourly. So we give a single dose of IV magnesium sulfate, that's 2 grams or 8 millimoles IV over 20 minutes to patients with acute severe asthma. PEF is less than 50% best or indicated, who have not had a good initial response to the inhaled bronchodilator therapy. So for patients that have not shown any improvement after the salbutamol and ipratropium, we would begin to give them IV magnesium. Alright. So the most commonly reported adverse effects of IV magnesium are flushing, fatigue, nausea, headache, and hypertension. So we monitor the patient, and these patients would most likely be in resus, so they will have monitoring attached. So following senior advice, if the magnesium still hasn't done anything, we would move on to consider aminophylline in severe or near fatal asthma only. So a loading dose of 5 milligrams per kilogram IV is given over 20 minutes unless on maintenance therapy, followed by an infusion of 500 to 700 micrograms per kilogram per hour. And we maintain serum theophylline concentrations below 20 micrograms per ml to avoid toxicity. So these patients are often dehydrated and are hypovolemic and would benefit from fluid replacement, right? Because beta-2 agonists and steroids may induce hypokalemia. So salbutamol, we normally give that for hyperkalemia treatment. So when we are giving continuous back-to-back nebs in salbutamol in asthmatic patients, it can cause their potassium to drop. Alright. So for these patients, we'll get crit care involvement if there's no improvement after all of those treatments. So we would consider tracheal intubation and controlled ventilation if, despite efforts to optimize drug therapy, the patient has a deteriorating peak flow, a decreasing conscious level, or coma, persisting or worsening hypoxemia, deteriorating respiratory acidosis, severe agitation, confusion, progressive exhaustion, respiratory or cardiac arrest. So one thing to note from the VBG or ABG, elevation of the PaCO2 alone does not indicate a need for tracheal intubation, right? So just a little statistic, worldwide approximately 340 million people of all ages and ethnic background have asthma with a high prevalence in some European countries, United Kingdom, Netherlands, and Scandinavia. Annual worldwide deaths from asthma have been estimated at 420,000, with 1,400 deaths reported in the UK in 2018. Alright, and we have some kids as well that have passed from asthma. Right, so we'll just show a few of them. So we have William Gray. He was 10 years old, and in 2023, November, he died from an asthma attack, and coroner ruled that it was avoidable. Also, we have Warren Dowling. He was 10 years old as well. He turned blue and died suddenly from asthma attack while playing on the trampoline. Alright. So, asthma is a serious condition, and if you don't react promptly to it, it can be fatal. In minutes, it can be fatal. Some persons, you would take your inhaler and they would say they have been taking their inhaler to no effect, it's not been working. So they need to see medical help immediately and come to the emergency, because asthma is an emergency and it can lead to cardiac arrest if not treated promptly. Alright, so of course we'll still do what I didn't mention. We'll do bloods, we'll still do an ECG, a chest x-ray to rule out if there's any infection, and if the bloods are indicating infection, you would still get your antibiotic. Alright, so that is it for asthma, guys. You can leave a comment down below in the comment section. Remember to like, share the video as well, and subscribe. Until next time, see you in the next video. Thanks for watching.